Remember, this is a very unnatural process. I'm forcing air into those lungs. It's the reverse relationship than we normally breathe. So with that comes a lot of issues. Barotrauma, just because of that positive pressure airway that I'm creating that breath with. A volutrauma, so it's excess amount of volume within those alveoli and they're expanding too much. So I can give them too much volume. I do want them open, but I can have them open up too much. And then you have your biotrauma as well, some type of inflammatory response within inside those alveoli. You have that ventilator-associated lung injury as well. So I can lose my surfactant, my lung compliance, where they expand out, decrease down. So I can create that with this lung injury as well. And then several acid-base imbalances. So your respiratory acidosis, your respiratory alkalosis. Other options that kind of don't fit in one of these other categories, some type of infection otherwise, ventilator-associated pneumonia, electrolyte imbalances, and just overall muscle loss. Because that mobility is definitely going to be impaired, regardless if you're walking around with your patient, getting them up to the chair, dangling them off the side of the bed, doing that range of motion type of exercises. They are going to lose muscle mass. They're not using those muscles adequately, and then they're not getting adequate nutrition on top of that. So all of this kind of plays into a factor because of the ventilator. Neuromuscular blocking agents. Now we're going to get into what types of drugs we're going to commonly see with our ventilated patients. A neuromuscular blocking agent. This is a paralytic. I'm paralyzing my patient. My patient is not compliant with the ventilator. He's fighting it too much. Maybe his airway is too constricted. I need to relax that out. I'm paralyzing my patient so my ventilator is able to do all the work possible. He has no chance of fighting it if he's paralyzed. This is only a paralytic. It does not have a sedative effect and it does not have an analgesic effect. All right. If I'm paralyzing my patient, do they need to have an airway?
Yes.
I'm killing their respiratory drive, right?
Yes.
They are not able to contract that diaphragm and initiate that breath on their own. They have got to be on a ventilator if I'm pushing a paralytic. They have to be. Don't be like the nurse at Vanderbilt. Please make sure they're on the ventilator. Okay? Okay. I've had travel nurses too say, go push the paralytic, and then I walk in and the patient says, hey, how's it going? Can't do that. All right. Please be safe when you're pushing these types of drugs. These are very high risk types of drugs. Common examples, really the big ones that you're gonna see is your rocuronium. This is what we usually give at East Alabama. And then other places will give vecuronium as well. Rocuronium or vecuronium. It'll come in these vials and you can actually just push it and just have a kind of a temporary paralysis for an extended period of time just to get your patient through whatever situation they're going through. Or you can also put them on a drip as well. So it's a continuous infusion of this paralytic. So during like COVID times, I've seen real bad anaphylactic reactions, and so we give things like this to help out with that. What is my role as a nurse when it comes to giving these neuromuscular blocking agents, these NMBAs? Got to monitor my vital signs. I'm paralyzing everything out. So I got to make sure my vital signs are there. Got to make sure I have adequate blood pressure. Make sure I have adequate heart rate. If I don't, I can give other drugs to help out with that. Airway management, big one right here. Airway management. Make sure they have a ventilator. Most important. Like I said, it is not a sedative and it's not an analgesic. It's not for pain management. It's only a paralytic. So, paralytics versus sedation. If they're on a paralytic, they better have sedation on board. You do not want your patient fully awake but paralyzed. That's torture, all right? We don't want that to happen. So they gotta be on some type of sedation in combination with this. Yes?
I know we talked about it way at the beginning of the slides, when we briefly mentioned meds. Which one was it that would raise potassium?
Sucks.
Oh,
Sucks
not any of these, I'm sorry.
Yeah, not these. Yeah. So yeah, gotta be on some type of sedation with this. Now the very bottom point right there, peripheral nerve stimulator. This is how I'm going to determine how paralyzed my patient truly is. So that's what we have here. It comes in several different kinds, looks, shapes, all roughly the same thing. Very similar to like a TENS unit if you've ever seen one of those or used one of those. My goal is to deliver 4 little electrical impulses. I'm stimulating this nerve right here, and then I should develop a twitch off of that because I'm stimulating that nerve. We also call this a train of 4 because it delivers 4 little nerve impulses to hopefully get 4 twitches. Because it's a paralytic type of agent, I don't want a over paralyzing effect. And then I can have that muscle breakdown, that muscle weakness that occurs. And if they're on it too much or too long and have too much at one time, it can have a very long lasting effect with this. So that's why it's very important to have one of these. With this, remember, I've got to be on sedation if I have a paralytic. So once my sedation is set and it's fully maxed and my patient is fully sedated, I'm never touching my sedation again. We don't want to wean down our sedation and then potentially wake up while they're on the paralytic. So you're going to maintain your sedation all the time. Once I have my sedation on board, I'm going to get a baseline for my train of 4 or my peripheral nerve stimulator. So here on the side, you can control your power or your settings on here, and there's also some buttons too on other models. And you're gonna slowly turn up this nervous stimulator, and you're gonna do a train of 4 where it delivers 4 twitches, 4 electrical impulses. You're watching for this twitch on your patient. If you're doing your radial nerve right here, your little thumb is gonna twitch right here. You can also have the temporal nerve right here as well, where you place 2 electrodes on it and the eyebrow will twitch slightly. As I'm turning up my power, I'm looking for 4 strong, steady twitches. So for every impulse, you'll see this thumb move pretty strong 4 times. At that point, I know that's where my baseline is. Once I give my paralytic, I'm going to reassess again. And depending on what your hospital policy is how often you're going to check it. When I recheck my train of 4 after getting my paralytic, and I only see 1 twitch on this thumb, for instance, then my patient is over paralyzed. I'm not getting enough nerve stimulation to make that thumb twitch. I need to turn down my paralytic some. Then I'll reassess again in an hour. If I still have 1 twitch, then I need to go down even further. Our goal is 2 out of 4 twitches. That's our goal with our paralytics, 2 out of 4 twitches. Let's go the other way. I can push my paralytic, or I have on a continuous drip of my paralytic, and then when I do my train of 4, I see 4 twitches on my thumb. My patient is not paralyzed enough. Then I have to go up on my paralytic. Again, I check it again in an hour, and then maybe I have 3 out of 4 twitches this time. Still not good enough, but I'm heading in the right direction because my goal is 2 out of 4. So then I can up my paralytic a little bit more to get them to that goal of 2 out of 4 twitches. Reassess again in an hour, and then hopefully I get that 2 out of 4. That makes sense? sedation wise. So if they're on the paralytic, I gotta have sedation on board as well. Propofol or Diprivan, that's gonna be your big one. Main thing is that initiation and continuous steady anesthesia property, that sedative effect. That's our goal with propofol. That's what works with propofol. Big things with propofol to know. No analgesic properties. This is not pain relief. This is only a sedative effect. So I have a sedative effect and then I have a paralytic agent. Now I need something for pain. And we're gonna talk about fentanyl in just a second. So no analgesic properties on this. Other things with propofol, it's got a very high lipid content. It's real fatty, it's fat based, that's how it's made. It looks like a big old glass of milk, that's it right over there. So you gotta have specialty IV tubing, and then you gotta change that IV tubing every shift. Because of that high lipid content, it can clog up that tubing along the way, cause like a downstream occlusion, and then you have to rechange it anyway. So every 24 hours, or every shift rather, you're gonna change this IV tubing out. If it's very high lipid based, what do I have to worry about with my patient?
Cholesterol.
Cholesterol, okay, specifically which one? HDL is your happy ones. So your triglycerides, they're gonna be elevated. My liver is working on overdrive to hopefully filter those out. But I have a high lipid content, I'm gonna have a high triglyceride. So we gotta monitor those frequently if they're on propofol. So you'll get triglyceride labs every so often. Again, monitor your vital signs. They gotta have an airway. The good thing about propofol is a very quick half-life. It takes hold real fast, so they'll even push it in like endoscopy, and maybe they just have like an oral airway or a nasal trumpet just to maintain that patency of that airway, and they can bag them if they need to keep that airway open. And then they can do their procedure in about 10, 15, 20 minutes, and then you can wake back up from it. It's that fast. Right? So it's really good for your patients. You had an endoscopy, didn't you? Did you get propofol? Did it work really fast, I'm assuming? Yeah, I mean, it works pretty quick. Every time that I, do what?
Chuck's favorite.
I said, good night.
Propofol does not come in an IV push, it's only drip form. You will see your ICU nurses want to give your patient what's called a hug, and so they will flush the propofol line to give an extra sedative effect. That's not best practice, but you will see that. We really like our hugs in ICU, that our patients will love because they're getting hugged often. So you will see that though, okay? But that's not best practice, that's not what's standard. It's gonna come in these specialty bottles. It's a glass hard bottle. Now, I've got my sedation on board, I've got my paralytic on board, but remember, none of those have any analgesic properties, any pain relief properties. So that's where this fentanyl is gonna come on board. It does have that pain relief property. This fentanyl is real powerful type stuff. It can come in an IV push form, and it can also come in an IV drip form. Make sure they can maintain their airway with this. I've seen a couple instances where they do a fentanyl drip and they don't have some type of ventilator or some type of airway in, but you're monitoring those patients really closely with this. Big thing with our fentanyl, our goal is to kind of balance it all out. Have that sedative effect, have that pain effect with it. That's our goal. Again, if I'm introducing that paralytic to my patient, I'm maxing out my sedation, making sure they are fully out of it. I'm maxing out my fentanyl as well, my pain relief, so they're in no pain. So they're fully asleep, they're fully not in pain, and then I can put that paralyzer on there as well. You don't want your patient fully awake with it. With fentanyl, it comes in specialty tubing. I did write it down in my notes, but it's here. Fentanyl comes in specialty tubing. So for all your other tubings, it has the little injector ports on it, right? Where you can hook up another IV line, or you can flush the line to your IV access. With fentanyl, there's no ports along the tubing. Why is that?
You can't accidentally flush too much.
Okay, kind of. And so Josh can't steal any of the fentanyl, okay? Because he heard in Montgomery fentanyl is $1. Or Sam can't steal it, you know? Anybody, family member that comes in, they could hook a syringe up to it real fast, pull out 10 c's of the fentanyl and take off, and you would never know. So it's just kind of an added barrier, layer of protection for somebody potentially stealing it. With all these sedation meds and your fentanyl as well, they're gonna be in a lockbox as well. Just so someone can't take the whole bag of fentanyl and just take off. Never seen that before, but I guess it could happen. People are crazy, so who knows? No. Other options we have. Medalazam or Versed. This has that sedative effect as well, that amnesia effect. This is not pain relief. This is more of a sedative add-on as well. Usually we're going to be on propofol and Versed if we need more sedation. The propofol is not cutting it enough just by itself. So we might add something like this Versed right here as well. With any of your sedation meds, maintain that patent airway. Make sure we're not causing any respiratory distress or depression with it. You don't have to be on an airway system of some sort with Versed. And then we have what's called dexamethasone or Precedex. It's a lot, it's a mouthful. I have to say it real fast, otherwise I can't say it. But Precedex, all right? It comes in an IV drip form only as well. And with this, the big benefit with this is it doesn't cause as much respiratory depression with this one. My patient does not have to be on the ventilator with this one. I can give them this, I can sedate them, they can be perfectly calm and happy, but they don't have to be on the ventilator or any type of airway. Sounds great, other than one of the big side effects of Precedex is bradycardia. If you're not careful and you're not constantly assessing your patient and weaning this as appropriate, or you give them too much too fast, you can cause bradycardia, where your heart rate's in the 20s and the 30s, and it'll sustain. Happens often. This is a very temporary setup. You shouldn't be using Precedex for long periods of time. You will see it, but you shouldn't be doing it. Same with all your other sedation type drugs and your paralytics. Very short-term fix. We may have to prolong it. Our goal is to get a kind of nice happy medium. You don't want them fully out of it, but you don't want them fully combative and awake either. How am I going to assess my level of sedation? Any thoughts? Drew, what you got back there?
Oh my god, that's
Sedation, yeah, you hear it all the time when you work. You got a score and another score.
RAS.
RAS score, your Richmond agitation and sedation score. You have your Glasgow coma score as well, which is really to see how awake my patient is, and then we also have what's called a CAM score as well, CAM positive or CAM negative. If you're CAM positive, you're altered, you're confused, you're not following commands. If you're CAM negative, then you are awake and alert, following commands like me and you. Your big one in your ICUs is going to be this Richmond Agitation and Sedation Scale. This is Natalie's favorite. She likes to talk about the RAS score often. Would you like to talk about it?
Oh, I can.
Okay, go ahead.
Why would you want me to tell you about it?
So, Richmond Agitation and Sedation Score, or RAS score, starts off at 0. That's me and you. It goes to +4 to -5. What's -5, Natalie?
-5 was the patient in room 05.
Let's not break HIPAA, but yes. So
I didn't say any names.
you didn't say names, that's okay. We all know what we're talking about. So -5 RAS. They are completely out of it, unarousable. They're obtunded, they're in a coma, something like that. any type of verbal stimuli or aggressive physical stimuli where you're doing that aggressive startle rub, you're pinching their finger beds, causing some type of painful reflex or response, they're not doing it. When you're on your heavy sedation meds and you're maxed out on those and you're paralyzed, you're gonna be that RAS -5, hopefully. This is not our intended goal to be down here. There's only select patients that should be at a RAS of -5. You gotta have an order for that RAS -4, -5. And then as you work your way up this score, the more awake your patient becomes. Usually our goal is gonna be a RAS of like -2 if they're on the ventilator. So when you talk to them and you walk in the room and say, hey, so-and-so, they're gonna open up their eyes for a little bit. They're a little bit groggy, and then they kind of drift quickly back off to sleep. And that's kind of that happy medium that I wanna be at. On the reverse side, you have a +4 or combative. Your patient's swinging at you. He's fighting you, he's biting you. He's fighting against that ventilator. He's coughing and gagging, trying to rip the endotracheal tube out, that kind of stuff. Let's see. One of my patients escaped his room and he was butt naked. He grabbed an O2 tank and started swinging it at people. That's a +4 combative RAS score. All right. Called security. They came in and tackled him to the floor, took him back to the room. That's +4 combative. That's what you're thinking about. And there's anything in between. So you'll see these RAS scores posted throughout. A lot of times you get the little badge buddies too to put on the back of your badge so you understand what a RAS score is. A physician's gonna set this goal for you. He's gonna give you an order. You don't get an order for any of the plus values, okay? You're not getting an order to keep him at a +4 combative, all right? You're only getting an order for the negative side of things. How sedated can I keep my patient?
Use plus just for charting.
Plus side is for the charting only to justify you giving something else. I can't just go into every room and say, you're getting some Versa today. I gotta have some reasoning behind it. My patient's anxious, they're CAM positive, their vital signs are showing me that they're anxious. Their heart rate's elevated, respiratory rate's elevated, BP's elevated. They're a RAS of +2. Then I'm painting a whole picture of why I'm giving that drug. And then I can put a narrative note into saying different things. Really painting a good picture.
Is it the amount that makes it like a -5 compared to a -1, or is it a different, like, would Versed be different than giving them like the first one that you said?
It really depends what you're wanting to accomplish. If they are at a 0 and you have a goal for a RAS of -5, you want sedation on board, you want pain management on board, and then you're gonna probably have to have a paralytic on board as well. And so they're gonna order those drugs for you, the physician will, and then it's your goal to titrate those, turn them up and down, how you see fit, to maintain that RAS score.
That feels scary. Like, what if they just weren't like, what if you thought they were -2, they were actually like a -4, and you just gave them way too much medicine?
Then you can just slow it back down.
That's
It's a
true.
balancing act. It's a very delicate process. It's hard starting out to get them to a perfect RAS score. The physicians get really excited when you do, because they think the night shift nurses always want them at a RAS -5 and the sleep, that we always oversedate our patients. Maybe we do, maybe we don't, but that's what they always think. That's the stigma. Other drugs that we're gonna have on board. So we're moving away from our sedation stuff, our paralytic stuff. Now we're moving to something like a mucolytic. So one of your favorite ones, guaifenesin. Everybody loves guaifenesin. We've all given it at some point. The other name for it, Mucinex. Another example that's gonna be more for our ventilator use, that we can actually do a nebulizer treatment through the ventilator to deliver it as they're inhaling. It's gonna be this acetylcysteine or Mucomyst. Mucomyst is going to break up those secretions. That's our goal. Make sure they're not as sticky, They're a little easier to cough up and out. I'm giving those to break up those secretions so I can have that inline suction go down and get out some of that excess sputum, that thick, nasty, cruddy type sputum. That's my goal with this. Usually it's gonna be administered with some type of bronchodilator. So I'm opening up that airway, breaking up those secretions, thinning them out, allowing me to get all that stuff out as best as possible. Other uses for your mucomist, you'll also see it for Tylenol overdoses as well in the ICU setting. So just something to think about.
Is that the one that had the cork, you pushed it down and you mixed it and re-administered? It's a weird, first time I seen it in ICU. And it's something you pushed it down into the. Salbutamol.
Oh, no, that's a glucocorticoid, yeah. You're talking about the tiny little vial, had the orange plunger in the middle and you press it down? Yep, no, that's salbutamol. I thought you were talking about the antibiotic, which was kept too at first. No, it comes in this vial right here, and then, let's see, I have a picture of it too. Comes in these.
Yeah, I've seen it.
So it's kind of like a breathing treatment or an albuterol treatment that you would get at the house. And so it comes in these little packs. You'll tear off the end of this. This is gonna be kind of a respiratory thing too, but you'll tear off the end of this, and then they'll put it in that humidifier, and as the humidifier works, it's going to instill that into them. So that's our goal with those mucolytics. With this, if I'm breaking down those secretions, it's gonna be easier for them to cough those things up and out. I gotta have suction at bedside, I gotta have that inline suction ready to go. I'm also gonna have that respiratory assessment, making sure I'm checking on them frequently, making sure they don't have that mucus plug because they were able to finally get some of that secretions out and I'm not plugging off their airway. Remember that ventilator safety, they're gonna cough and gag for a while, so if they pop off the vent, I gotta be able to hear that alarm and know, oh, my patient's off the ventilator, I need to reattach them to it. Because if they cough too much and cause excessive force out, it can actually pop off that tubing. If you're not careful watching it, then your patient is not ventilated for an extended period of time. And you can have some trouble effects with that as well. Again, it's respiratory. It's mostly gonna give this, same with a lot of these other drugs we're gonna talk about here in a second. Your beta-2 agonists as well. Your big ones with these are your albuterol, your epinephrines, and your racemic epinephrine. These are gonna be a nebulizer treatment as well. Our main goal with our beta-2 agonist is relaxing that smooth muscle, creating that bronchodilation, opening up that airway for better lung compliance. Basically, your implications for these drugs, your mucolytics, your beta-2 agonists, are roughly gonna be the same. Vital signs, make sure my airway is patent, is safe. My ventilator safety, make sure I know my high alarms from my low alarms and how to go about fixing those. Labs, why did I put labs on there? Specifically for albuterol. Albuterol can bring down what?
Potassium?
Acid? It can bring down my potassium,
Potassium is right.
right? That's our quick fix for our high potassium levels, albuterol treatments. Last drug we're gonna talk about as far as airway compliance goes is our anticholinergics. The big one, kind of the main one that you're gonna see or give, or respiratory therapy is gonna give, is your Atrovent as well. Remember, it has your anticholinergic properties, so if I'm getting this with like a Benadryl or something like that, I'm really gonna dry my patient out. It's drying up these secretions. So if I have a lot of that combination, I'm getting rid of all that excess fluid, urinary retention, dry mouth, maybe some hypovolemia, dizziness. Let's do this last slide and we'll go to the house. So we'll talk about ABGs next week. With the removal of our endotracheal tube, or we call it extubation. Weaning methods for this is gonna be box 26.9, page 619 of your book. When we talked about our ventilator modes or ventilator settings, remember our assist control was the most invasive. We worked our way down to the SIMV setting, and then we worked our way down further to the pressure support setting. So that's one way we can determine our readiness to remove that endotracheal tube. If they are able to tolerate those settings as we go down in intensity, that's potential for removal. As I'm doing that, I'm also getting an arterial blood gas to see how they tolerate it as well. If their arterial blood gas values look okay, another sign for readiness. Another thing is called this ABCDEF method. So airway, breathing, that coordination of care. So get the pulmonologist on board, get the respiratory therapist on board, the nurse. We're all gonna collaborate together for that readiness part. Delirium prevention. I don't want my patient to become altered or confused. I want him to be alert and oriented so he is able to participate in these types of breathing trials. How do I do that? Make sure they're awake during the daytime, weaning down my sedation as appropriate. And then if they need to sleep at night, maybe increase my sedation just a touch per my physician orders so they stay in that circadian rhythm. You're supposed to be awake in the daytime, you're supposed to be asleep in the nighttime. Exercise, that range of motion, that's gonna be your E. And then the family involvement, encouragement, giving them strength, give them that therapeutic communication, kind of that will or that drive to get better. Like I said, extubation is the removal of the endotracheal tube. First, we're gonna gather our supplies and assess our patient for the readiness to remove this with our supplies, some type of other airway supply, so whether that be a BiPAP or a CPAP mask, maybe on that for a short period of time, and then they have that just at night. In the daytime, they could switch over to a nasal cannula. Maybe it's a high flow nasal cannula or something called an OptiFlow, where it delivers a lot of liters of oxygen, and I can actually give them a little bit of FiO2 as well. So there's several options out there. Before removal, I'm going to hyperoxygenate my patient and clear out their airway as much as possible. As I'm pulling this endotracheal tube out of their airway, I don't want anything left behind, because they could potentially inhale that again and cause a serious infection. With that infection, they may not be able to overcome it and may have to go back onto the ventilator. So hyperoxygenate, and then I'm gonna deep suction, get all that secretions out as much as possible. As I'm doing that, and after I finish, the respiratory therapist may extubate the patient, pull out the endotracheal tube, and with that, we're gonna encourage our patient to cough and deep breathe. As they're coughing and deep breathing, I have that Yonker suction, that oral suctioning, that's connected to the wall as well, getting any excess secretions when they may cough up so they don't swallow them or inhale them back. Continue to remain at the bedside after they get off the ventilator. Again, this is not a time to take a break. Just because your patient is improved doesn't mean you can go do whatever. In the first couple hours, it's very critical that we assess this patient frequently. They could have an altered reaction where their airway closes up. So they could vasoconstrict because of that irritation, that inflammation that has occurred from that wear and tear of that endotracheal tube. So that might be while they have something or develop something called stridor. With stridor, that's when we're gonna give that racemic epinephrine. Open up that airway, vasodilate that airway to prevent those bronchospasms from occurring. Questions about anything?